All right, assalamu alaikum. Thank you for joining. We're going to go ahead and get started with our Behind the White Coat session. Today, we're joined by Dr. Rabia Iqbal, who's going to be discussing her career as a rheumatologist. You can go to the next slide. All right, so this is the agenda for the event. We're going to start with introductions, and then we'll go straight into the physician presentation. And then we'll end the Q&A. We'll end the event with the Q&A and the certificate for attendance. All right, my name is Alina. I'm the founder of MWM, and I want to welcome you all to MWM. We are a nonprofit medical association for Muslim women, pre-health students, professionals, and practitioners. We've done many events over the past 2 years, including in-person events, including iftars with various university organizations. And then we've done online events like this, Behind the White Coat, panel discussion events, and things like that. So now we'll go straight into our physician presentation led by Dr. Rabia.
Okay, assalamu alaikum everybody. My name is Rabia Iqbal. So currently I'm a second year rheumatology fellow at Columbia Presbyterian Hospital, and I'm almost done with my fellowship. I'm only 1 month, there's only 1 month left. Just a little bit about me. In terms of my background, I was born in Pakistan and I came to the US with my family when I was 5 years old. So I had all my schooling here. I'm the youngest of 4 siblings. None of my other siblings are in medicine except me. And I decided on pursuing medicine over doing a PhD in chemistry or biochemistry, which was my college major. Because I liked the idea of helping people and actually making change through patient interactions, because how you speak to a patient and the encounter you have can actually lead to a pretty drastic impact in their lives. And that's what I noticed during my volunteer experience, and that me to pursue that over doing a PhD or going into a research career. And I was the first to go to medical school in the US in my extended family as well. So this slide is just a collage of activities I like to do. So sorry, a lot of it is just like personal family stuff, but I do like going to brunch cafes. So for example, in Brooklyn, we have a really nice one called Milk and Honey. And then there's Alice's Tea House. So I have some photos from there. And I think the one with the taco is actually an Uzbek restaurant. And I try to maintain my health, which is very important when you are in a stressful career. So I like to do Pilates. I think it's better than yoga personally. And I also like tennis, although I haven't been doing that as much because you need the right space to do it. But I used to do it more when I was in college. And then I like hanging out with my family. I have sisters, I have nieces and nephews. And we like to go to amusement parks like Legoland and Hershey's Park, and like places in nature upstate near the Finger Lakes. I have some photos from there, and from Maine, the lighthouse. And then just like going around the city, like Governor's Island with the ropes, and botanical gardens. That's where you see the Christmas trees. And I also like reading, both for just like leisure reading and for information. So I like reading self-help books. One of my favorite books is Thinking Fast and Slow, which tells you a little bit about patterns of thinking, and higher orders of thinking, basically, which I think is good for college and like beyond, once you get to that point. I also like the book Quiet. It's about the power of introverts because I'm on the introverted side, so it helped me navigate certain things about that. And I like reading about Islamic history. So some books that I read recently, Secrets of Divine Love, reconstruction of religious thought in Islam and a biography on Prophet Muhammad Sallallahu Alaihi Wasallam. So those are some things I like to do outside of work. So my pathway to medicine was I attended Barnard College in New York City, where I majored in biochemistry, and I did research in an organic chemistry lab at that time. I'm not sure why. I think I just liked the professor, and I was like, oh, he's gonna make a good research mentor. I wasn't necessarily thinking about med school at that time, but and I volunteered in hospitals, like two different ones, or rather, it was a hospital and a clinic. And I was in the emergency room, which is great because you get to see a lot of different kinds of patient cases in the emergency room. So I think it was a good experience. And I also tutored other college students in like Orgo and like other subjects. And I took one gap year just because I didn't feel ready to apply, mainly because I didn't feel ready to take the MCAT. I was quite intimidated by it. And after having done a major like biochem, which required many hours and a lot of homework, I was just too tired to study for the MCAT. So I took one gap year. It was challenging finding a one gap year position because most of the gap year positions required 2 years. But I kind of kept looking around until I finally found somebody who was willing to take me for a year because I really didn't want to do 2 years. So I found a biochem lab at Cornell that took me in for a year. And it actually was pretty nice because I got a publication out of it, which I totally didn't expect. But sometimes things are, unexpected in research. So, and then I went to Columbia Med School. I got in there, and I think part of it is like my interviewer that I had was really nice, and I think they really liked me. So I think that was part of the reason. Obviously, besides doing well in college and having all those activities in. And then after med school, I went to TJUH, Thomas Jefferson in Philadelphia for my residency in internal medicine. And then I came back to Columbia for rheumatology fellowship. And I am going to be starting my attending level position at NYU Langone in Brooklyn in September. So that's my journey. And I included some photos of my graduation from Columbia Med School, and those are my parents on my sides, and my poster presentation from one of the Rheumatology Society meetings. And on the bottom, I included like my residency group, who I became really friendly with. You spend so much time together, you all end up just becoming friends. And then that last picture is the Liberty Bell, of course, just to show that I was in Philly. So what is rheumatology? According to one dictionary I found, it's somebody who is a superhero, but that's not true. Rheumatologists do cool things, but they're not necessarily superheroes. They study the musculoskeletal system and systemic autoimmune diseases. So rheumatology is not the only field that studies the musculoskeletal system. There are other fields, for example, orthopedic surgery and physical medicine and rehabilitation, or PMR, which is also a branch of internal medicine. They also study musculoskeletal diseases. But what sets rheumatology apart is that the musculoskeletal diseases have underpinnings in the immune system. So there's something wrong with the immune system that is causing those diseases to occur. The most commonly affected places are the joints. So that's why I included a picture of the joints. But those are not the only places that are affected. Really any organ can be affected by rheumatic diseases. So during my journey, I went through internal medicine residency, and that consists of 3 years. The first year is the intern year, where you're expected to really do a lot of the, uh, frontline work in terms of seeing the patient. Like you'd be the first one to see the patient, take a history, examine them, write the note, talk to the nurses, make sure the orders are in, do any scut work. Depending on the program, of course, some programs require more scut work than others. Uh, Once you're done with that, then you become a senior for the other 2 years, and you're responsible for basically telling the intern what to do, but also making sure the team functions and making sure you delegate tasks to the interns and the medical students on the team. And if there's any outstanding tasks, then you would be responsible for them. And residency is the period of time in your medical training where you have the least amount of time off. Um, so you have to work long hours, you have to work most weekends. So there's very little time off, but the ACGME, which is like the Graduate Medical Education Committee, put in some regulations that allow for some time off so that the programs are not abusing the residents. And these changes occurred many years ago, but basically they can't tell residents to work more than 80 hours a week. They need to give them at least one day off if they work for 2 weeks straight. They need to make sure they have at least one full weekend off per month. So those changes are there just to make sure that the residents have some sort of sanity and well-being in their lives during this stressful period. Um, and if the residents like it really exemplify being a good senior resident, they can get chosen to do a chief year, which is a 4th year. So it's after you'd be done with your residency. Some people say this is a political position. I don't know. Like I think it just depends on the program. Some programs tend to be more political than others, so I don't know. And then why did I choose rheumatology? Um, I think what I liked about it, well, one, it kind of just built upon all the knowledge that I had acquired in internal medicine during my residency. So, you spend some time in cardiology and pulmonology, gastroenterology, so you learn those organ systems. Rheumatology, uh, the diseases affect all the organs, so you have to have some baseline knowledge of all of them, but in a way that's kind of advanced. It takes it a step further. And the other thing I liked about it is that it deals with the immune system, which honestly I think is the coolest system in the whole body. Um, it is highly intricate and highly effective. Um, and it just, it's like one of those things that makes you realize that this could not have been like formed from evolution. So that's what I liked about it. And then the other things that I liked about it is that it has an outpatient focus. Um, so you don't really have to do a lot of hospital call, which is nice because it does save time. And you get to see the same people over a long period of time. The patients tend to be generally younger than maybe, for example, in cardiology. Um, and they tend to be more female patients. And also you get to see people get better sometimes very quickly. So those are all things that I liked about it. Other things that people may not know is that you actually get to do procedures as a rheumatologist. So you get to do ultrasound on people's joints, and you get to give them injections in their joints, like in their knees or other joints, that can make them feel better instantly. So I think it's very, very rewarding. There's also very exciting new treatments, some of which you may see on commercials even, but they do, you know, uh, they do go back to basic science, so it kind of builds on that knowledge that you've been learning since college even. And I just included a photo of a patient's hands who has long-standing rheumatoid arthritis, and you can see that the joints, the metacarpal joints, are very enlarged, and the hands are deviated um, sort of to the sides. So those are very classic findings you would see in rheumatoid arthritis. And rheumatologists have to be very keen about their physical exam because it does clue us a lot about a patient's underlying condition, whether they have rheumatoid arthritis or perhaps some other type of arthritis. So your attention to detail becomes really important in this field. So life as an attending. So attendings have the highest level of responsibility than anyone else in the medical team. And they are ultimately responsible for the patient outcomes. So, theirs is the final plan. And once that plan is implemented, whatever becomes of that, they're technically liable, even in terms of, legal liability is ultimately theirs. So whatever orders their intern is putting in, they're actually responsible for it. So they're responsible for teaching all of the members of the team how to deliver the best patient care and exemplify that. And one way they do that is by bedside rounds. So each morning the attendings will go, and this happens with hospital medicine most frequently. The attendings go around to each of the patients they're responsible for, and they will discuss ask the patient their symptoms and discuss the plan for the day. If there are family members there, then they would also talk to the family member and discuss the plan. Sometimes the nurses even join the rounds, and the attendings are sort of responsible for addressing their concerns and making sure the whole team is functioning optimally. And even though the responsibility is higher, in some ways being attending is more flexible because you don't have to be in the hospital. In the case for hospital medicine, you don't have to be there the whole time. You can choose to come and go at whatever times you'd like, at reasonable hours, of course. And you get to decide when rounds start, for example. So everybody else is supposed to basically obey you in a sense. So there is that level of hierarchy in medicine, and attendings are at the top. Rheumatology attendings in particular are slightly different from like a hospital attending. So for them, their focus is mostly on the outpatient setting. And a lot of the attendings do some inpatient consults. So consults are when you get called by the primary hospital team about a particular question that may or may not relate to rheumatology, and you are required to come in and see the patient in the hospital. But there may be some, if you're in on call, so to speak, for the hospital for, a week at a time, a week per month, let's say, you may not get called all of the days. You may get called two of the days. So overall, the inpatient time tends to be very little. In the outpatient setting, the clinic can be busy. You can be seeing up to 14 to 20 patients per day for up to 5 days. Some rheumatologists like to have a day or half a day off just to be able to call patients back about their test results, about their labs or imaging findings. It depends on, which clinic you're working under. Some allow it, some don't. So pathways that rheumatology attendings can take include being a clinician, which means you're just seeing patients. Clinician educators, you're working with trainees like residents and fellows, and clinician researchers, you're seeing patients some of the time and you're also doing research. And the research tends to take precedence over the seeing the patients, basically. So I just included some pictures of rheumatology attendings checking the joints of a patient, which is a lot of what we do in the clinic, and also another attending looking at x-rays. So we do look at a lot of imaging, of course. So in terms of rheumatic diseases, not sure how familiar you guys are, but there's like several main categories of rheumatic diseases we see. But the most common ones that I want to highlight, one is rheumatoid arthritis, and it's kind of named after this disease, and the other is lupus. So in both of these diseases, RA and lupus, there is a female predilection. So in RA, women are 3 times more likely to develop it than men. And in lupus, it's even greater. It's 90% of the patients are women. In my own patient panel, I would say about 95% of my patient panel right now is female. Um, with these diseases, people always ask or wonder, like, who gets them? Who gets, rheumatoid arthritis? So there's always an interplay between sort of nature and nurture, right? So nature meaning it's your genetic makeup. There's actually an attending I work with who's done research into genes that are associated with rheumatoid arthritis, and there are actually several correlations. So there's a loci on the HLA-DR molecule. So those are basically like the receptors that are on your T cells, T cells and B cells that identify self as self. So certain variations of that can predispose you to having rheumatoid arthritis. And that's why it tends to sometimes run in families. But the genes are not the whole picture. There's also other factors like your lifestyle, so smoking, or being like very obese, those can trigger inflammation. So they can predispose you to having RA. So we always advise patients to stop smoking. And we work with, other fields as well. So we work with, for example, primary care doctors. They usually help people with stopping smoking, like giving them nicotine replacements and all. So we let them know, like, we try to emphasize, okay, let's get this patient to stop smoking, especially because they have RA. Sometimes if the patients come after, having RA for a long time and no treatment, their joints can look terrible. Like their knees can be, bent and they cannot straighten them. It's called a contracture. So we have to tell them to go see surgery because they're going to need a knee replacement, because the knee is so bent, they won't be able to straighten it. The other thing we worry about, if they've come in with untreated RA, they can have heart disease because there's inflammation throughout their body. So it can actually accelerate the process of forming a cholesterol plaque in your coronary arteries. So they can get heart attacks more frequently or heart failure. So sometimes we have to, manage them along with the cardiologist. Um, so that's RA. And then lupus, similarly, like many organs can be involved. We often see the most common things we see are skin involvement, so all sorts of rashes. We work very closely with our dermatology colleagues because sometimes we can tell what rash it is, but sometimes we can't because it could be a fungal rash or some other rash. So we try to coordinate with them to make sure the patients are getting better with, the lupus treatment. If not, then maybe go back to the drawing board and see what else could be causing the rash. And the other, like the most feared complication for lupus is actually kidney disease. Especially if they have severe lupus, they're more likely to have renal involvement or kidney involvement. And those patients end up, in some cases, they end up needing a kidney transplant. So we have to work closely with our nephrology colleagues to manage those patients. The other interesting thing about lupus is that not only is there a female predilection, there's also a predilection for Black people in particular, and also Hispanic. So in some ways, this disease is a prototype of a disease that tends to affect minorities, right? So it tends to affect women of color more so than any other demographic. So in some ways, in treating these patients, you're almost being an advocate for those minorities, because they tend to be really treated the worst in the healthcare system of today. Um, so that's I think part of what makes it rewarding to treat this condition and be in this field. Um, Besides these diseases being incredibly interesting. So uh, we usually tell, let's say you're a primary care doctor or general doctor, so or some other specialist. So when should you refer patients to a rheumatologist? Some people don't really know, even some doctors I feel like may not be aware of this, but if you have somebody who's coming with joint pain, especially if they have swelling in the joints, then they should be evaluated by rheumatologists because swelling means that they could have inflammation. Other things, rashes, especially a so-called butterfly rash on the face, that's something we see classically with lupus. Finger color change in their fingers or toes, that could indicate something called Raynaud's phenomena, which we manage even if it's without any other associated condition. And if they have, any sort of really joint pain, I think is reasonable to get evaluated. If the primary care doctor is unable to basically manage the pain, then the next step would be to refer them to rheumatology. Um, so I just wanted to go over two case studies that I think highlight some of, or give you a little taste of what kind of patient care we do in rheumatology. So case one is a consult I saw in the hospital, and this was a 20-year-old healthy male who was admitted for 4 weeks due to a 4-week history of maculopapular rash, oral ulcers, and low-grade fevers after a hiking trip. Now, this first bullet point is something we call a one-liner. A one-liner in medicine is a sentence that's supposed to summarize all the important parts of the patient presentation. So it challenges you to be very concise and yet accurate. That's what we aim for in medicine, is precision or accuracy and also being concise. Um, so anyway, um, maculopapular just means, there's flat spots and raised spots. So I included a picture of what this is not the actual patient, but this is a picture I found that's similar from the internet. Because we're not allowed to actually put patient pictures that would violate HIPAA, the patient confidentiality. So basically we had the patient had several lab tests done. They had a complete blood count, which is, a very basic lab. We basically check it on everybody. And it showed a low white blood cell count. So now if somebody's coming in with fevers and a rash, doctors start thinking about things like infection. And with infection, you normally have a high white blood cell count, but this patient paradoxically had a low white blood cell count. And they also had elevated ferritin. Ferritin is something called an acute phase reactant. An acute phase reactant is something that the liver produces once there is some sort of inflammation in the body, whether that's caused by infection or autoinflammation in his case. But the ferritin, I didn't include the values here. It was somewhere in the thousands, like tens of thousands. That's not something you would see with just an infection. So that's what made us concerned for something called macrophage activation syndrome. I included a picture of macrophage activation syndrome here. What happens is that you have activation of macrophages, as the name suggests, and they start eating up the other cells. So you can see this macrophage, it's eaten up the red blood cells here. And this is a very concerning condition because, you can quickly become very anemic, or your platelets can come down, you can start bleeding, and it has a very high mortality rate, like 50%. So clearly this patient was really sick, and he's only 20 and he was perfectly healthy before all this happened. Um, so the primary team wanted to make sure there wasn't anything else causing it because, like I said, the fevers and the rash, you could see that in infection. All of the infectious workup was negative. And they also noted he had some enlarged lymph nodes. So he had a biopsy. They were concerned it could have been a lymphoma or leukemia, because those things can also cause fevers and rash. But the biopsy was negative. It showed some non-specific sort of inflammation. So finally, we called our dermatology colleagues and they did a skin biopsy and it showed non-specific connective tissue disease. So that's a general bucket of diseases of the connective tissue or the extracellular matrix. So diseases of the extracellular matrix include lupus, scleroderma, other conditions. So ultimately, we check for a bunch of antibodies, and this is what we do in rheumatology. We have a lot of antibodies that can be tested, and the antibodies clue us into what condition the patient has. So this patient ended up having positive lupus antibodies, specifically double-stranded DNA, Smith, and RNP. I didn't write it here because I don't think you need to know this right now. But basically, these are antibodies that are in the criteria for lupus, in the ACR criteria. That ACR is American College of Rheumatology. So they came up with, based on research studies, they came up with a bunch of criteria that if you fulfill a certain amount, you classify as having lupus. So this patient ended up having lupus and we thought he had MAS secondary to the lupus because autoimmune diseases, if they are severe enough, can throw the body into this highly, inflammatory state called MAS, which is a life-threatening state. So we quickly started treatment with steroids. Steroids work really quickly. They're great. They get patients feeling so much better so quickly, especially if they're, at risk if they're at high mortality risk. That's the thing you would want to use the first, because it's the fastest. Long-term steroids are not good because they can cause a lot of problems. But for now, he needed the steroids. We also treated him with something called anakinra. This is a medicine that is an IL-1 receptor blocker. And I included a picture of what that looks like. So I think you guys study these in college in like biochem. So it comes back. That knowledge is going to be useful to you guys. So IL-1 receptor blocker is interleukin-1. Interleukin-1 is a cytokine. So this is a molecule that activated immune cells release and it promotes inflammation. So what anakinra does is it basically blocks the receptor. So the IL-1 beta in this case cannot bind to the receptor. So the receptor is not activated and you don't have promotion of the inflammatory cascade. And it works fast. And the patient got better very quickly. So I just included a table of differential diagnoses that we thought about in this case. And some of this I already pointed out, but basically if somebody's coming in with fevers and a rash, you start thinking of 3 large buckets of diseases. And this is a good way to organize your thoughts in internal medicine because there's so many diseases, so you have to come up with a way to like categorize them. So we like to bucket them into infectious, autoimmune, malignancy, or other. So in terms of infection, you have parasites, Lyme, Rocky Mountain Spotted Fever, babesiosis, anaplasmosis, or ehrlichiosis. You have viruses like Epstein-Barr virus, cytomegalovirus, herpes virus. Sorry, this was supposed to be parvovirus, HIV, syphilis, hepatitis B or C, and then bacterial infections like just bacterial cellulitis, meningococcal infection, mycoplasma pneumonia. So these are all things that can actually, cause these symptoms. So he was tested for all of them, believe it or not. For autoimmune, you have things like lupus, which he did end up having. Related condition is MCTD, mixed connective tissue disorder. So, because he had the skin biopsy, we realized it could have been one of two or three possibilities, either lupus, mixed connective tissue disorder, or I didn't write this here, but scleroderma, technically. And other things, so adult onset Still's disease is slightly different. It's an autoinflammatory disease. I won't get into the details of this, but other things would be vasculitis, which is inflammation of the blood vessels, sarcoidosis, Behçet's disease, which is exceedingly rare. It tends to happen along people of Silk Road origin. And I have seen cases of it though. I've seen cases of all of these at this point. Erythema nodosum, and then malignancy, as I mentioned, lymphoma, leukemia. Paraneoplastic means related to an underlying malignancy. So you could have, pancreatic cancer or stomach cancer, and those cancerous cells can produce autoantibodies essentially that can mimic an autoimmune disease, but it's not an autoimmune disease. Yeah, so the immune system can do crazy things. And then some additional things, I won't talk about them. This table I actually prepared for my during my residency for the interns, so I won't delve into the details. But this is just to show you like how we sort of think in internal medicine and rheumatology. So the other case is a case that I saw in my clinic. So this is not a woman who was in the hospital. I started seeing her in clinic. I inherited her from one of the older fellows, or not older, a fellow who had graduated from the program. So she was a 60-year-old woman who presented to the clinic for follow-up for rheumatoid arthritis, and she had bilateral midfoot pain and swelling. And she was actually first diagnosed in the Dominican Republic, and she was Spanish speaking. At that time, she was started on methotrexate, hydroxychloroquine, and prednisone. These are all oral medications that we use for rheumatoid arthritis. And she had no improvement. At some point, she relocated to the United States. But, the interesting point to note here is that methotrexate, hydroxychloroquine, and prednisone are cheap medications. They don't cost a lot. A lot of the other medications in rheumatology are very expensive, like the TNF inhibitors. And not only are they expensive, they're often not available in developing countries. So it would be hard to find infliximab in the Dominican Republic or upadacitinib, which we eventually put her on. These are available in America and in the Western world. But somehow the pharmaceutical industry does not make it so that the cost allows them to be available in developing countries, unfortunately. So this patient, wasn't doing well when she was in the Dominican Republic. I'm not sure exactly if she relocated to the US for this condition. I think she already had some family here, so she relocated, and luckily she started seeing us. And once she started seeing us, we put her on biologic, quote unquote, biologic treatment. These are mostly injectable medications or sometimes available through intravenously, and they are pretty effective for rheumatoid arthritis. So we started on infliximab. She didn't improve on it. Then she was switched to another biologic, sarilumab. And these are very targeted medications. So infliximab is a TNF inhibitor. So it blocks TNF, which is tumor necrosis factor. That's a major player in inflammation, and it causes joint inflammation, muscle wasting. IL-6, interleukin-6, is a cytokine produced by immune cells, and it also is an important player in the inflammatory cascade and causes some off-stream effects from inflammation as well, like cachexia. So she tried both. The sarilumab, which is the IL-6 inhibitor, helped her initially, but the effect wore off. Sometimes we see this in rheumatology, a medicine that works at the beginning, sometimes the effect just comes off. Unclear why, but we hypothesize that it may be due to autoantibody formation against the drug itself. The reason why that can happen is that these drugs are actually antibodies themselves. They're monoclonal antibodies. So you can form an antibody to an antibody, and therefore the effect can be negated. So anyway, we luckily had some other options for her, and we have a good repertoire of medications now that we can use for people in rheumatoid arthritis, which we didn't have, let's say, 10 years ago, 15 years ago. It's actually very exciting. So we switched her to upadacitinib, which is a selective Janus kinase inhibitor. You guys may be familiar with that word, Janus kinase. I'm not sure if you are, but it's involved in this JAK-STAT pathway. The JAK-STAT pathways are very important in biology overall, and they are important in immunology and like oncology world as well. So these are very interesting drugs. They have a potential to be used in a lot of different conditions, even in like dermatology and gastroenterology. But it is approved to be used in rheumatoid arthritis. And once we started that, she actually got so much better, luckily. And not only that, she was having low back pain and sacroiliitis, which is separate from the rheumatoid arthritis. And it helped both, her feet and her low back as well. And the other thing to note about this case is that with rheumatology, you always have to have an open mind, because in her case, we knew that she had rheumatoid arthritis. So when she developed back pain, we thought it would be, it wasn't related to an inflammatory process, because rheumatoid arthritis does not cause back pain. It affects only the small to medium joints. It does not affect the back. But, I still got the x-rays, and it turned out she had sacroiliitis. Sacroiliitis is inflammation of these sacroiliac joints, which I included in this x-ray. And that's something we see with a separate condition called ankylosing spondylitis. Sorry, it's a funny name, but what it essentially means is there's inflammation of bones in the pelvic area. And this condition is completely separate from rheumatoid arthritis. And if I hadn't checked the x-rays, I would never have known and assumed, that she had maybe just osteoarthritis. But it was also helpful because then we picked a drug that could be used in both conditions. So the upadacitinib is helpful for both ankylosing spondylitis and for rheumatoid arthritis, and it ended up helping her with both of those symptoms. So, and then I just included a diagram with the, different biologics we use, infliximab, adalimumab, golimumab. These names all end in AB, or MAB rather, which means that's a code, ending for monoclonal antibody, which these drugs are. And these ones block TNF in particular. And then anakinra, I think I mentioned before, blocks IL-1 receptor, and tocilizumab and sarilumab block IL-6. So what's exciting about rheumatology is that you get to use that basic science knowledge you learned from college and all the way to being an attending. So I just wanted to talk about applying to medical school because I think at the point where you guys are at in your careers, you're maybe starting to decide to apply to med school, or maybe just wanting to learn more about the process to see, if it's for you or not. So, and I was there, I was at that point in my in my career where I was having to make those big decisions. Um, so just a few pointers. When you're applying to med school, I feel like there's a pressure to have a lot of extracurriculars, which is great because I think extracurriculars supplement and add to your, classes, and they help you form your identity and explore your interests. But I think what's better is to, you know, is quality over quantity. So you want to do extracurriculars that are really meaningful to you, that tie in your interests and values, that you would feel like proud to talk about in an interview, for example, with somebody. Um, so that are meaningful, essentially, than to have a lot of random ones that don't necessarily tie together into intrinsically into who you are. So that, and then I think in general, doing roles that show initiative, so like starting a new club that has great value to you, great meaning to you, or being a leader in one, those are generally regarded more. But it doesn't mean you have to do those. It just means they may pique someone's interest more. And the rumors about grades mattering, yes, the grades actually matter a lot, especially the MCAT scores. I think some places have just cutoffs where they will just not look at your application if your score is below a certain level. And from what I hear, scores are getting more competitive. So I think for better or for worse, you do have to study and make sure you get those good grades. And then research, I think, is generally, so a lot of med schools are part of, academic centers, and academic centers are all about research. So a lot of those interviewers are going to be interested in hearing about research. So it's a good thing to have. I think there's always a struggle between doing research that you're genuinely interested versus doing it sort of just to have it. It's a fine line. I mean, do what feels right. I don't think you'd be wrong either way because, if your goal is to get into med school, then you should probably do it. Um, and then the other thing is letters of recommendation. I would say letters of recommendation should come from people who know you well and people who are nice, because those are the people that are likely to write you good letters of recommendation. I know this from experience. Um, if you haven't spent a lot of time with that, professor or mentor, or they don't know you personally, then you could fall into the trouble of having them write a letter for you that backfires on you. Because they may say, oh, you haven't spent enough time with them to know you. So I would just steer clear of that and just be mindful of who you're asking. And a good letter, like an excellent letter of recommendation is better than two like mediocre letters, I would say. So pick and choose. And it's very important to sort of tour each med school and learn the vibe of each place, because you want to go to a place where you feel like you would, you know, in some ways fit in, or at least in terms of the learning environment, to have a learning environment that will suit your needs, because med school is very intense, and you don't want to end up in a place where you're constantly feeling like, you know, that this uh, pace wasn't for you, or that you don't have anybody else to relate to. So do check out each place and be mindful of that. It does matter. You have 4 gruesome years ahead, so be mindful of that. And then the last thing rather, is to just trust the process, because sometimes it can be scary if you've been waitlisted for a place or even rejected. But I think the system just ends up so that you end up in the place that's best for you. So trust the process. So this slide is about my experience as a Muslim woman in healthcare. And I think there's pros and cons, as there are to any situation, but you know, maybe more cons in this case. Nonetheless, I think it's good to share this with you. Um, in particular, so I would say the cons were mostly in medical school. After that, things have gotten better and better and better. In med school, as I mentioned, I went to Columbia Med School, and I was the only Muslim woman there. There was no other Muslim woman. I think maybe there was one Black Muslim male there, who I was friendly with, but nonetheless, there were some Asian like students, like non-Muslim Asians, some non-Muslim Indians as well. But again, like nobody who had my background at all, um, and that sometimes can feel isolating in certain situations. Um, but I think what I ended up doing was sort of just continuing my social circle that I had started during college, who I was very close with, and my family. So in terms of social needs, I think I fulfilled it through there. Um, I don't know if that was the smartest move. I think maybe if I would try to socialize more with my colleagues that were not necessarily of my same background. But the thing that got in the way was something called imposter syndrome, which can be relentless, and it can make you feel like you're not good enough as your other colleagues. Um, so if you feel yourself getting imposter syndrome, you should talk to somebody, seek help, maybe try to even find other people from other places of your background who can relate to that. So, but never feel like you're alone, which I think I learned perhaps a bit too late in during med school. So, uh, besides that, I think, and it's important to maintain activities for well-being. So exercising in med school, that saves you. It helps reduce some of the stress, um, and facilitate your long hours of studying. So aside from that, other things that pertain to me being a Muslim woman and healthcare, in particular in med school. So the reason why med school was overall like an experience that like a period where I had maybe some of the worst experiences was because you're at the bottom of the ladder. You're at the totem pole, bottom of the totem pole, and you have residents, you have um, even interns and residents and fellows and attendings, even nurses, they're all above you, so they can sort of, in some ways, boss you around a little bit. And when you're a minority, you kind of feel that even more than if you weren't. Um, and if your superior, the supervisors are not cognizant, then they may give in to their inherent biases, right? So an unfortunate example is when I was doing my ED rotation, um, one of the attendings, who was generally not regarded as a good attending, I will say, um, told me that, you know, he was like, "Oh, you don't belong here. I think you're meant to be a housewife." So that was a very, I was really taken aback. I actually reported that incident. Um, and that was a macroaggression. So not just a microaggression, that was a macroaggression. Because, I spent so many years in college and gap year working hard to get there, only to be told that I'm supposed to be a housewife. So that was uh very hurtful. And that attending is still there. So you know, that's the unfortunate part, is when you're an attending, there's you get away with a lot of things um that you probably couldn't as a med student. So for better or for worse, that is how the medical system hierarchy works. Um, I think it's starting to change a little bit, but again, it depends on where you end up, really. Columbia, I guess, tends to be more old school in that sense. And in fact, a lot of the Ivy Leagues are, so just be careful. Um, on the flip side, I feel like I felt proud to be who I was, like to represent myself as a Muslim woman, because I knew my values and the values that my parents raised me with. So I welcomed any questions about the religion. Um, and those questions tended to come from patients. They did not come from my med school colleagues. And I'm not sure why, but I guess sometimes I feel like people who end up in the medical field, they already, you know, yeah, they may not be as open to accepting change, unfortunately, as other people. At least that was my experience during Columbia Med School. And so, but regardless, I think I felt uh, satisfied in caring for the patients and in answering their questions, um, and other things. So I had to, like, I feel like there were times when I had to be a little more conscious about not giving in to some of those macro and microaggressions that I mentioned. Because as long as you have the goal in sight, you develop the strength over time to sort of overcome those things. And as long as you have enough activities of your own personal well-being, so things that help de-stress you and keep you interested, um, you know, um, in your daily routine, then you can sort of overcome that. And just using your faith to sort of ground you as well and help you find solace. That was another thing that helped me. And I think things got better. So once I was not at the bottom of the totem pole, I felt like I could exemplify the behavior that perhaps some of those attendings could not offer me, um, such as just being kind to to your med students. Um, so it got better over time, and I think once you're an attending, then you get to set the pace. You get to set the mood of the team, and you get to exemplify what it means to be a leader in the healthcare field that is cognizant of their biases, that treats others with kindness, even if they're, below them on the hierarchy. So once you get through that phase, then you can do whatever you want, essentially. Um, so I think that's all what I was gonna say. But I can welcome any questions.
Yeah, so now we're gonna go ahead and get started with our Q&A session. Before we start with live questions, I wanted to ask you, Dr. Rabia, questions that were sent in by our followers on social media.
Mhm.
So the first question is, what was one moment in medical school when you realized you really wanted to go into rheumatology?
So I think I actually became interested in the beginning, like during, I think it was the end of first year or beginning of second year, we had a block. So we had a block on all the different organ systems, and we had a block about immunology and MSK, like musculoskeletal. And, I just became fascinated with the immune system. So, I, I wanted to go into a field that studied it further, which rheumatology does. Um, but I didn't Well, actually, I would say at that point, I knew I was interested in immunology, but I wasn't necessarily thinking I was gonna go into rheumatology at that point because I had come into med school thinking that I would do um, perhaps like ophthalmology or OBGYN. So like I was thinking of some other things, but when I did my clinical rotation, so those are done during third year. I liked internal medicine the most, um, because you get to see the patients for a long time, and you can be very comprehensive in asking them different questions. And I just felt like patients always wanted to share all those details with me for some reason. Everybody interacts a little differently with patients, but whenever I interacted with them, they would want to just share all like the little details. So that kind of reinforced my thought that internal medicine was the right field for me. And then once I got into internal medicine, I thought back to the time of me being that like first year med student and liking immunology. I was like, well, rheumatology kind of combines all those things. Um, and the other thing, so endocrine, I think, is similar in some ways because it has, that that similar relationship with patients. Um, but it doesn't study the immune system. So again, I think rheumatology was a good fit. And then hematology, oncology, you also do study the immune system to some extent. But I felt like taking care of cancer patients, for me personally, it was hit or miss. So there were things I liked about it. You can really comfort people, but at the same time, you see a lot of death, you see a lot of end of life care. And at some point, I thought that it may wear me out. Whereas something like rheumatology, you get to see a lot of people get better quickly. So I thought it was a happier field. So that was my reason. But by the end of med school, I think that's when I was more sure of it. And then during residency, I confirmed that by just taking more electives in like hemonc and in rheumatology and endocrine just to solidify that.
Yeah, that's great. And also like when you're going into residency and it's coming to apply to residency, along with like choosing a field that made you happy or, you like you said, like you really like studying the immune system. What do you think other people should look for when it comes to choosing a field? Um, Given that every field has its own like challenges, but also like rewarding aspects.
Yeah, I think it's important to pick a field that genuinely interests you, right? Because you're in it for the long run. You're going to be spending your whole life doing this. So it should pique your interest and curiosity for sure, hands down, because at some point even schedules can be adjusted, but your level of interest will probably not, right? So pick something that generally piques your interest and something that you feel like you would be adept at. So you'll see, when you do your clinical rotations, you'll see which fields you naturally tend to do better in, large categories like surgery or ENT, or OBGYN, pediatrics, neurology. Based on your evaluation, I would say like you should try to pick the subjects that people feel like you're doing better in when they evaluate you, because that will help you in the long run too. And combined with the subject that also interests you the most. And also you should think about lifestyle because certain fields like neurosurgery, for example, it can be a lot more hours in the hospital, like more call. As long as it interests you, if you're willing to put in those hours, then by all means you should go for it, But you should know um, all the expectations out of each field before you go into it. Yeah.
Yeah, I agree with that. And even as like a pre-med student right now, I know like it's so early to decide what field you want to go into, and I know that's going to change like during medical school. But I think that like whatever field you're talking about, when your face like lights up about it or you feel like you could talk about it for hours, I think that's like a something you could also consider when choosing a field or even choosing which medical professional you want to be because there's so many different careers within healthcare. So,
Yeah. And it's good to like see somebody in that field. So if you're interested in a field, go shadow somebody. Even if you don't have an elective in it or a rotation in it, please go see it. Even if you're remotely interested in, for example, PMR, there's no clinical rotations during third year, but if you ask your, you know, um, clerkship directors, they may help you get an elective in that field. So if there's something not on your schedule and you may be interested in it, you should try to take initiative and find electives in it to explore it further. Because otherwise, 10 years from now, you would regret like, oh, why didn't I do an elective in this field? Like it would have been cool. So explore all your possibilities because that's the time, like in between college and med school, that's the time when you're exploring different things. And the other thing that people often bring up is financial. I personally, I feel like that weighs below everything else. So if you have special circumstances, maybe you want to think about that. But in the long run, you're going to be spending all your life doing this. So if you're going to do something just because you make more money, honestly, I don't think that's the best decision to make. It's not good for the patients either.
yeah. And then during the presentation, you also mentioned that you see mostly female patients. And I know you mentioned like certain conditions that affect the female body and things like that. But what are some other reasons you think that may be?
Why the conditions tend to affect females the most? Or sorry,
Yeah. Yeah, and like
oh,
your patient demographic is mostly female.
so it's also interesting because women tend to go to their doctor appointments more than men. So I certainly have males who have lupus and even RA, but they don't come as often to their appointments for whatever reason. Um, um, and the other thing is with rheumatic diseases, it is thought that female hormones like estrogen play a role in promoting autoantibody formation. Um, so I don't know exactly why that happens, but it is thought that they play a role in autoantibody formation. Um, and um, yeah, and that I think that's as far as I know the relationship between females and autoimmune diseases.
And then the last question that was sent in was, as medical professionals and those that are going into healthcare, what can we do to help alleviate and advocate for the ongoing medical genocide that is happening in Palestine?
Yeah, I think that's a very good question and very relevant to the times today. Um, so from what I know personally, like there's organizations that help send doctors to parts of the world where conflict is happening and where emergency medical care is required. So guys may have heard of Doctors Without Borders. Um, that's one of the I think the largest ones, and they have doctors in Palestine and Gaza that are there, serving. But it's tricky because, there's obviously safety issues too. So everybody should play whatever role they have in whatever capacity they have. So I think spreading awareness, is definitely something we can do as healthcare professionals, whether we're students or, trainees, or residents or fellows attending. Um, and that starts by, you know, maybe attempting to discuss with our colleagues. So me personally, like, I feel like I've discussed with my immediate colleagues. So maybe not so much my supervisors, but I've discussed this with a few of my like other fellows in rheumatology because I'm at the same level as them. So I think there's a kind of collegiality already. Um, but it's also a little tricky because, you may have some colleagues that are of a certain background, so that you don't know how they're going to feel or take it. But as long as you kind of approach it in a diplomatic way, sort of hear everybody out, never try to shut down anybody's opinion. Because honestly, I have an attending who became a doctor in Israel, so and I work with him, he does immunotherapy research. So you have to sort of, it's a fine line sometimes, you have to be respectful of everybody. You never want to put any human down, but still stay firm to your beliefs and values. And I feel like me being a Muslim woman who, I wear hijab to work, that already speaks a lot. You're representing the faith, and I think it's a kind of an honor to do that in some ways. Um, so be proud of yourself as a Muslim. Um, Never think of yourself as an imposter. As I mentioned earlier, having imposter syndrome for a lot of my medical training, I think, wore me down. So I would encourage medical trainees not to overcome that, right? You're this on the same level as all of your other colleagues, if not more. So just be proud, represent your faith, um, be tolerant of other people. I think exemplifying good character is always important as a Muslim. Um, and advocate wherever you can, in the right spaces. Um, it's just when you're in the medical field, unlike being a student, I think you have a responsibility to patients. So, if there's a protest happening and you have patients to see, if you are following the Hippocratic Oath, then I guess you have to tend to your patients first. But after you're done, then you can go to the protest. Um, I think in the medical field, we are privileged financially, so we can donate, of course, to the right people, to the right organizations that promote this cause, and to the doctors serving there directly. So that's one way I think would be ideal for us here, at least, that can't go over there. Yeah, I think those are the main ways. And, prayer, as a Muslim, of course, prayer is very important. So always pray for the people there, because, even as people of privilege and power, in the situation, I think a lot of people just feel helpless. So prayer is important and a way out from the situation, hopefully.
Yeah, I agree
In
with
my
it.
hospital, they actually have they the department of the chaplain department actually organizes weekly prayers, like non-denominational or interfaith prayers, which I think is a good initiative. So they invite like people of all faiths to come pray just for world safety. They don't specify, but you know, obviously this conflict is part of it too. You know.
Yeah, I agree with everything you said, and being in medicine and working in healthcare can be tricky to bring these topics up. But I think if you're focusing on yourself and as long as you're firm in your beliefs and things like that, and um, I feel like that will help to bring about change. And also recognizing that like the healthcare workers that are working in Palestine and Gaza and things like that, that they are our colleagues in healthcare. So recognizing that is really important. Um, but those are all the questions that were sent in. We do have a question asked here. As a rheumatologist, how is work-life balance compared to other medical professionals?
I think work-life balance is great in this field, and perhaps that's one of the reasons I decided to go into it. It is, you know, focused on the outpatient setting, so I think there's a little bit more control over the workload. And eventually, once you get to an attending level job, you can negotiate how many patients you want to see in a day, depending on the setting. Um, your weekends are mostly free. Um, so overall, I think it's great as uh, a Muslim too, right? Because then you have time to sort of devote a little bit more to your religious obligations too. Because you know, I always felt like I need to keep both, like my medical studies and I like studying, as I mentioned all the way in the beginning, I like reading those Islamic books too. Um, so I like having that work-life balance. Um, Even if you don't have a family or you're not married, um, you know, it's still nice to have that work-life balance, I think. Um, and there, I mean, it's not the only field that has that. There are certainly other fields. Sometimes I feel like if you're a researcher, there, you know, there's other instances where it can get busier. So some of my research attendings, they seem to be a little busier or more stressed, I think. Um, but they actually enjoy what they do because what their advantage is when a patient asks them, you know, if they failed everything and the patient is like, what else can we do? Then they can tell them like we're working on this experimental drug and enroll them in a clinical trial. So that field also has its own charm, you know, to become a clinician researcher. Um, but yeah, I think overall the work-life balance is good.
Yeah, I think also I've talked to other medical professionals as well, and using the term like work-life balance can sometimes also like not apply to some people's career. It's also like finding they said to use the term work-life harmony instead, because sometimes life gets in the way and you don't find that balance. But yeah, it's I agree with that. And I also find like inpatient the difference between inpatient and outpatient, knowing the difference between those two, because obviously those have different demands and things like that. So yeah.
And it also goes back to what I was saying earlier, pick a field that interests you, right? It's like, you know, the saying, if you do what you love, then you won't have to work another day. And it's true because if you really are interested in this field, you're interested in actually helping people make real change, which you can do as a doctor. You make real change and you'll see it. Once you guys are doctors, you'll see the change you're making in people's lives. Then you won't feel that, oh, you know, this is work. You'll just feel like you're just helping people. So yeah.
All right. I think that brings us to the end of our Q&A session. If you want to go to the next slide, we can talk about the short quiz and certificate of completion that we do. And I will share the link to that form in the chat right here. But it's just super short, 4 questions about this presentation and about rheumatology in general. And then after you complete this, we can send you a certificate of completion for this entire session. And then I think there's one more slide, just like a slide about MWM in general. Dr. Rabia, would you be able to switch to the next slide?
Oh yeah, sorry.
No worries. So this is just a last slide about connecting with MWM. We have a bunch of programs and opportunities for students. We have a volunteer program, a mentorship program, an ambassador program where you can start an MWM chapter at your own school. We recently started a chapter at GW here in DC, so that's exciting. And then we have different membership tiers if you'd like to join the community, and a bunch of opportunities to collab with us as well. But yeah, thank you guys so much for joining. Thank you, Dr. Rabia, for this very informative and educational session. I found it very beneficial for myself personally, and I'm sure to the rest of the attendees as well. But obviously, if you'd like to connect with Dr. Rabia, she's also one of our MWM mentors for our Flash mentorship program. So feel free to enroll in the mentorship program. But yeah, that brings us to the end of our session. Thank you so much for joining.